It's time.
அது அந்த இது ஆஃப் பண்ணிரு. என்னதுல இருக்குல்ல? Okay. Good afternoon, everybody. I welcome for this month GEM Televersity education program. So today we are planning to show the virtual live right hemicolectomy and other topics with the left hemicolectomy and how to tackle the perioperative bleeding and perioperative chemotherapy in colon cancers. This time we have made a little bit changes in the moderator. Actually, we have an eminent colorectal surgeon, Dr. Harish. He is going to show the virtual live right hemicolectomy, and another faculty, Dr. Shankar, will be talking about the left hemicolectomy, and another medical oncology, he will be talking about the perioperative chemotherapy in colon cancer. And we made our final year postgraduates, FNBs and DNBs, as a moderator, because we heard that there are many questions which was asked by the postgraduates was not answered properly during this session, monthly. So we thought this time we will ask the postgraduate to moderate, so that whatever questions arise by them will be answered by the faculty now and then. Okay, with this I will go to the introduction of CME with CVL with 5 minutes, then we'll go for the live. The CME with CVL is the gold standard for colon cancer. We'll see what is this concept of this CME with CVL, because the adoption of TME for rectal cancer with a significant decrease in local recurrence and improved survival, the surgeons then they were started doing a complete mesocolic excision for colon cancer, and it was introduced by the Hohenberger, is a German surgeon. But during the same time, Japanese they were talking about, they introduced D3 lymphodectomy. We'll see both are same, and during the same period, even before that, so from GEM Hospital, Dr. Palni will introduce as IRITA technique. We'll see what is one by one. The definition of CME CVL is a complete mesocolic excision with central vascular ligation. CME is nothing but it follows the concept of tissue mobilization by releasing the planes during the dissection following embryological planes. That is throughout from esophagus to rectum, that is anal canal, the dissection will be between the parietal and visceral fascia. So the same concepts apply in colon resection. So there will be between the mesocolic fascia and the retroperitoneal fascia, that is the mesenteric fascia. The central vasodilation is a flush ligation of the artery supplying to the involved lesion or the involved bowel of the tumor. The D3 lymphadenectomy means removing the main lymph nodes of the feeding vessel of the tumor located in the colon. So this is the two main difference. The CMVC was introduced by the Hohenberger, that is in 2008, and he showed a more than 15% improved survival when compared to the standard colon resection for colon cancer. But during even before that, 2004 itself, this man, Dr. Palniver, introduced the IRITA technique for the right colon malignant tumors. And we have also published the same, but not much difference between the CMU CVL. So when the East were talking about the D3 lymphadenectomy with Japanese, and West they said it's a CMU CVL. So many papers have now compared the CMU CVL with the D3 lymphadenectomy, and we'll see what is the difference. Not much difference, both are same, only in the central vascular ligation is bit different actually in CMU CVL for the colon, whereas in D3 the depending upon the tumor, the blood supply of the tumor. So all of you must be knowing that is just go. This is the diagrammatic representation where the plane of dissection will be there in CMU CVL, and you can see there is a Toll's fascia which covers the retroperitoneal structures, and there is a mesocolic fascia which covers, that is the visceral layer of the colon, and this retroperitoneal will be the parietal layer. So the dissection will be going in between that, and sometimes in advanced cases you can even go removing the Toll's fascia itself, but we always go like a mesophacial separation. So with this principle, what are the main concept? Because sharp dissection of the visceral plane from retroperitoneal plane, so avoid breaching of visceral facial layers. An origin of colonic arteries can be well exposed and ligated centrally, so the maximum lymph node harvest can be done. And outcome was superior to the standard colonic resection, that is more than 50% overall survival there. So this is the main concept of CVL, this diagrammatic representation, and all the advantage. What is the D3 lymphadenectomy? If you say, you can see the there are various lymph nodes. You know how the lymph node spread from the tumor is there. So D1 will be pericolic, and D2 will be the intermediate, and D2 will be the intermediate, pericolic and intermediate. And D3 there will be a central lymph node, that is the complete dissection of D3. So in D2 we'll be removing the pericolic and intermediate, whereas in D3 we'll be removing all the pericolic, intermediate, and the apical lymph nodes, that is from the origin of the lymph nodes, origin of the artery. So this is the diagrammatic reference of D1, D2, and D3 dissection. So I think we'll be seeing in the live, virtual live videos of the right hemicolectomy in short. So this is the concept. The main thing, the concept in right hemicolectomy, the variation in the anatomy of the vasculature, both artery and vein, you should keep in mind. Most of them, the right colic artery may not be there in 20 to 60% of the patient, and there may be variation in the middle colic. And the main thing is you have to take the origin of the right branch of middle colic in the right hemicolectomy, whereas in the extended right hemicolectomy you have to take both the lymph node, that is you can see the 222 lymph node, that is from the origin of the right and left branch of the middle colic, whereas 223 is from the trunk of the from the origin of the middle colic itself, where you may have to take in case of extended right hemicolectomy or subtotal colectomies. And this D3 lymphadenectomy by Japanese, they have found like this. If you have a feeding vessel right from the tumor, then on either side 10 centimeter will be removed. If the tumor is away from the feeding vessel, then the tumor side there will be 10 centimeter, and opposite side that only 5 centimeter from the origin of the vessel will be taken. So that is the concept. This varies according to the site of the tumor where it is present in the colon. So the importance of right colon vascular anatomy has been well established by the Japanese paper. This was published in 2021, and now they said For a right hemicolectomy, the present concept, there is a need to understand the complicated vascular branches. Very, very important. So, in order to dissect the lymph nodes and to further identify and dissect the correct blood vessels, the main morphologies of the right colic vein, middle colic vein, and the gastrocolic trunk are highly varied, with both the head of the pancreas and duodenum in close proximity. And they have told in that paper that is D3 lymphadenectomy in case of right hemicolectomy is considered to be a highly difficult surgical technique. So the conversion rate from lab to open is around 10 to 20%, mainly because of the bleeding. So the understanding of vascular anatomy is very, very important before planning to do the right hemicolectomy surgeries. And the main concept I want to share, particularly for the postgraduates, this is one important paper by the Japanese Takashai. He has well written about the vascular blood supply of the colon, and he divided into four quadrants, and each quadrant is supplied by a main vessel and one of its branches. So according to, he has divided to right colectomy, right hemicolectomy, left hemicolectomy, and subtotal and total colectomy. In case of segmental, only one main artery is divided. In case of hemicolectomy, two main arteries are divided. External hemicolectomy, two main arteries plus one branch is divided. So you should know, if it is a right colectomy, you can see only ileocolic and right colic is divided, not the right branch or middle colic. In right hemicolectomy, only the ileocolic, right colic, and the right branch or middle colic is divided. That is hemicolectomy. So with this concept, I would ask Dr. Harish. He will be showing the virtual live video of right hemicolectomy. I think in between, the moderators can ask the questions so that we can answer them now and then.
Okay, play பண்ணுமா? Okay, now Dr. Rajapandian sir has given a fantastic introduction to CME, CVL and right hemicolectomy. I will be starting with the procedure. The first photo what you are seeing here are the port positions. First, what we are going to do is put a 10 mm camera at the umbilicus for the diagram. Once 10 mm camera is put at the umbilicus, then a suprapubic 10 mm camera is placed. This will be our main working port. Under vision, we place rest of the ports. One in the right iliac fossa, one in the left iliac fossa, one in the left hypochondrium. Optionally, so the first camera what we'll be using is a suprapubic camera. This will be used for the IRITA technique, that is the dissection from caudal to cranial, from below upward dissection going into the IRITA plane. We'll be using this camera. The red color represents the area of dissection using this camera. Once the IRITA is completed, then the camera will shift to the umbilicus. This is mainly for the suprapubic compartment dissection. The camera is shifted upwards. So then we have the left working port, the right working port, and T is the traction port. Also in the right hypochondrium or in the epigastrium, if you require, you can always put a secondary port for traction. With this, I will start the procedure. So now I'm going into the suprapubic port, into the umbilical port. This is for the diagram. This is a case of hepatic flexure growth. Initially, our investigation did not show any other tumor other than hemangioma. So when we did a diagram, we saw a small lesion near the diaphragm. Rest of the abdomen was unremarkable. And once inspection is done, then we proceeded to put the suprapubic port. You can see the bladder, sigmoid. So a small incision is put, 1 centimeter incision, and a 10 mm port is placed. This will be our first working port. The camera is shifted to the lower camera, to the suprapubic region now. And from there, this is a left iliac fossa, left hand working, right iliac fossa, left hand working port we are placing. And then under vision, the other two. You can see I'm palpating from outside and then placing the 5 mm port in the left hypochondrium. This will be the traction port. And then in the left iliac fossa, which will be my dominant side right hand working port, this is another 5 mm. The patient is put in head down position and right up. Once the patient is put in that position, then first thing we have to do is take the bowel loops away from the working. We need to go to the root of the mesentery. From there, we need to put an incision. In this case, if you see, there's some sigmoid is attached to the mesocolon, to the mesentery. So first, I had to release it from the mesentery. From the traction port, I have held the small bowel loops and have lifted it up. And the other two instrument with harmonic, I am releasing all the attachments. When we are dissecting here, we have to be careful about the bowel loops. as to not have a thermal injury on the bowel loops. You may not identify it immediately, but few days later the patient will present with a leak. So stay clear of the bowel, separate the tissues with blunt dissection, alternate between using the harmonic and using the non-active blade for slightly pushing away the tissues from the operating field. These are probably congenital adhesions, that is the appendix and the cecum. So as and when required, depending on how much traction I need, I decided to release the cecum, a part of it. This is right now I am doing this only for adhesiolysis purpose. So when we are giving traction later on, you can see we are going to hold the base of the cecum, base of the appendix for traction. As I am giving traction to the cecum, you can see slowly the Tolles fascia will come into the visibility now. Now what is this Tolles fascia? Like the holy plane of field where they first started the dissection, Hohenberger, then they realized later on that the same plane extends from cecum until the rectum. So they started using this plane. It is a loose areolar plane and it has two interfaces. One is a mesofacial and retrofacial interface, that is one towards the colon and one towards the gerotas. So it is in this plane, avascular plane, where we are going to concentrate our initial dissection. There are different ways of approaching the dissection, that is some people do medial to lateral, cranial below, and like sir said, this was first done, this procedure was first shown that it can be done this way was at GEM hospital. So once I separate the adhesions from the sigmoid, you can see the gerotas is being seen there posteriorly. We need to doubly make sure that ureter is not tented in this location. Usually we are safe, it will be little more deeper, but before applying the cautery in this section, make sure you push away all the tissue, identify what is below it, and then separate the tissues. So when we get into the right plane, you can see slowly gerotas is being separated from the mesocolon. You can do a blunt dissection as and when required. Either you can use a harmonic or a monopolar to separate. At this point, you will have gonadal vessels and ureter running below. So we have to be very careful at this point. This is one technique we use at GEM, to use a gauze and give traction to the tissues. You need to lift the mesocolon and the colon nicely anteriorly so that the tissues, the gerotas, get separated from the Tolles fascia. These are the last final remaining attachments of the sigmoid which I am releasing. Again, you can see the duodenum is already coming into the play. I don't need to go below the duodenum. You need to stay above the duodenum. So this root of the mesentery, in otherwise cases, we put an incision from the cecum until the root of mesentery where we can see the DJ flexure, and from there we proceed cranially. So umbilical port, we have put a holding forceps and passed it under the root of the mesentery and lifted the mesentery from one side, and another traction from left hypochondrium. The assistant is holding the cecum. So the entire mesocolon is lifted up, the right mesocolon. When we dissect, if you see a bare ureter, that means you have to know that you have gone one layer below. Ureter should not be completely bare. You should see a thin film of layer on top of ureter, which will guide you that you are in the right plane. See, now I am lifting the mesocolon. You can see the D2, D3 is there in the picture. Now we need to separate the duodenum from the mesocolon. The C loop of the duodenum has to be completely separated along with the head of the pancreas. Below you can see the gonadal vessel coming, and next to that ureter. IVC is coming to the picture now. Sometimes it may bleed, that nothing to worry in this location. You can use a bipolar or you can apply a gauze. Generally, I take 2 gauze inside, 1 gauze for compression and second for traction. So slowly, the duodenum and the head of the pancreas is being separated now. The head of the pancreas you can see now. Stay slightly away from the duodenum. Injuring duodenum is not a good idea at this point. The mesocolon is gradually being separated. Give proper traction. With adequate traction, if you just push the gerotas and the duodenum, they generally fall away. So you have to alternate between sharp and blunt dissections for this. Again, when using harmonic, be careful. It's a very hot tipped instrument, easy to damage the tissues. In this way, as we ascend upwards cranially, from D2, we need to reach D1. In all cases, it will not be the same because depending on the size of the colon, size of the growth, location of the growth, it may be slightly difficult to reach the hepatic flexure all the time. But as long as you go up till the colon, that's more than sufficient. This is nicely seen, C loop of the duodenum, head of the pancreas, separating the mesocolon from the head of the pancreas. That is separating from the colon. Now the traction gets shifted. You can see one transparent at where I am dissecting now. As I go deeper, the hepatic flexure is opened. That is a completion of IRITA procedure. Initial retrocolic tunneling technique, endoscopic tunneling. So we have created a tunnel under the mesocolon. If where possible, if we can reach this during the mobilization, hepatic flexure mobilization will be much easier when we go to the supracolic compartment. So once this step is done, we are going to keep a gauze on the C loop of the duodenum and the pancreas, because when you are approaching from above, it's easy to damage the duodenum. So if the gauze is there, it will act as a good protective layer anterior to the duodenum. Once that is done, the small bowel is put back in its, reflected back into its location. Now one traction is given at IC junction, the other traction is given in the to the middle colic vessels. You can see now the bowstringing effect is there, and you can see the pulsation of the ileocolic vessels, and you can, if you see little higher, you can see the middle colic vessels. So 5 centimeters from the ileocolic pedicle, you need to dissect all the tissues. That is the ileocolic pedicle. This is the superior mesenteric vein, and above is the middle colic. Ideally, it will be good if we can make a window at this point. Now, if you notice this mesocolon, we have already mobilized posteriorly. If we go deeper here, we will enter into that window. Sometimes we have to be careful at this step, because if it's a slightly bulky mesentery or if slightly the bowel loops are slightly dilated, sometimes that loop will be sitting right underneath that one. So either you can open here or you can go above. Once the window is created along, then you can start the dissection, continue the dissection. So I made a mark where SMV is going, and then slowly all the mesocolic tissue are being separated. Now first thing what I am doing here is searching for the superior mesenteric vein, because that will give me a good guidance, the only guidance towards which direction the dissection should go. So gradually, layer by layer, start releasing and start dissecting. When we start doing that, superior mesenteric vein will come into the play. So as I am dissecting now, the superior mesenteric vein. The bluish tinge what I'm seeing there is a superior mesenteric vein. Now once that has come, now that will give me a guidance. I need to go ascend along the superior mesenteric vein cranially. We need to clear all the nodes and the mesocolic tissues to the right side of this. See, in cases where you have a tumor in cecum or ascending colon or hepatic flexure, ileocolic D3 is a must. So when we keep this above the vein, if you are clearing all the tissues, it is considered as a D3. Now you see the ileocolic pedicle is coming and joining the superior mesenteric vein. This dissection, we need to identify the adventitia and ascend along the adventitia. It's a nice plane where it will very nicely open up between the mesocolon and the adventitia. See, that layer nicely opens up. Sometimes patient having paniculitis, this layer may not be very nicely separable. So we have to be doubly careful because that's when we end up injuring the vessels. Slowly, step by step, we need to identify the ileocolic vessels, artery and the vein. Ileocolic artery and the vein is the most common constant, and it is there in all the cases. So first we have identified the vein. Once the vein is identified, try to dissect and then look for the artery. We need to understand that artery can be there in multiple locations around the vein. It can go anterior to the vein and it can go posterior to the vein. Either it can be above or below. So whenever we are dissecting each and every tissue, we need to identify and make sure we are not cutting the artery in the process. Now you can see the gauze which we had kept posteriorly. It's coming to the picture now. This is the reason why we keep the gauze, so that when we do the dissection, by mistake, we should not injure the duodenum. Because gauze is kept, I can go a bit more confidently knowing that it is protecting the duodenum below. So I'm ascending along the lateral wall of the vein and clearing all the mesocolic tissues along with it. Outcome depends on a good nodal clearance. PGs who are moderating, if any question, any doubt is there, you can raise, anytime you can raise. Now you see the artery is coming into the picture. In this case, superior mesenteric artery is posterior to the superior mesenteric vein and ileocolic artery is posterior to the ileocolic vein. Little by little, take your time and dissect all the nodal tissues. Here you can use either a Maryland or a bipolar for dissection. Both are very good instruments and used for dissection. I'm separating the artery from the vein to make some space for clipping. You have to be very careful for giving the traction here. My assistant from the hypochondrium is holding the cut edge of the mesentery or the ileocolic junction. Excessive traction at this point can cause tear in the veins. So traction should be balanced between the requirement for the surgery. See, like I said, use bipolar. Immediately if small ooze is there, it can be cut, and then whatever tissues can be cut using the harmonic. You can use harmonic or ligashore. Finer work, harmonic works well. For thicker tissues, ligashore is a good instrument. Now you can see it's completely skeletonized. After skeletonization, next process is clipping and then cutting. You can use Liga clips or you can use metal clips. If you have adequate distance between the two clips, you can use ligature or harmonic. If not, you can use scissors. Now, once that is separated, now we are again separating the mesocolic tissues from the head of the pancreas. A bit of dissection, blunt dissection, and then bit of sharp cutting. See, the plane is just exists there. We just have to make use of those planes. Once the dissection, next will be searching for the right colic vessels. See, right colic vessel is not as constant as ileocolic. It's there in only about 48 to 50% of the cases, or another set of cases it may not be there at all. So it may origin from different location. It can origin directly from the superior mesenteric artery or the ileocolic artery. Sometimes it can originate from the trunk of the middle colic or from the right branch of the middle colic. So lot of variations are there. Because of these variations, whenever you are dissecting, you have to look for all these locations while proceeding. Many times we will be seeing a right branch of the middle colic and we'll be thinking it is a right colic and vice versa. So we need to be careful. So as we ascend and superiorly along the superior mesenteric vein, the next thing you will come across is the gastrocolic trunk. Here you will receive multiple branches, one from the right colic and one from the gastroepiploic and one from the middle colic and from the pancreas. You can see all three branches here, one coming from the gastroepiploic, one on the right side you have the right colic, and from the pancreas you are seeing one vessel, that is the pancreatic branch. All the vessels have been individually separated and then they have to be clipped. You can spare the pancreatic branch if it is not coming in the way of the dissection. Again, at this point, you can use blunt dissection or you can use bipolar for dissection. Now, once I have identified that, you can see middle colic vein is coming into the picture. When you find middle colic vein, you should know that you are very close by to middle colic artery. Generally, these two run together. I generally use bipolar here, or I can use a suction for blunt dissection to push away all the mesocolic tissues. Now you can see all the branches of gastrocolic trunk. They come in different variation. It is not constant. Sometimes right colic and gastroepiploic branch, those two fuse together and then drain into this one. Sometimes they individually drain. So there are a lot of variations. So from case to case basis, you need to trace the vessels and identify and then plan for clipping the vessels. Now you can see middle colic trunk has come into the picture. Once I see the middle colic artery, I need to identify both the branches, because when I did the diagram in this, the growth was at the hepatic flexure, just distal to it. So we decided to go for extended right hemicolectomy. So if extended right hemicolectomy, I have to clamp the middle colic artery at the base and remove both the vessels. So I'm just tracing to make sure it is the right and the left branches, making space, adequate space for clipping. You can see the nice pulsations of superior mesenteric artery, and you can see the two middle colic trunk and the two branches going from that. Any of these, right branch or the middle colic trunk, we can find the right colic. So we need to search for these locations. So if I am going to go extended, then I have to clip all the branches and then separate it. Because the tissues were a bit fibrous, I decided to first clip and then proceed with the dissection. Right colic clipping. This is the branch from the gastroepiploic branch being clipped. Once all those branches are clipped, one by one, it is cut. Not necessarily that they have to be clipped and only then cut. You, as and when you encounter them, you can clip and cut immediately. So that way you will have more space while dissecting. I generally tend to identify as much as possible. making a window behind the artery to place a clip safely. Now I have placed the clip on the trunk of the middle colic, and then I have to disconnect them. Once this is done, see, we have gone from extracorporeal anastomosis to intracorporeal. So what we are doing here, along the right branch, I am ascending towards the colon. Assistant has already held the point where I am going to transact. So from there, the mesocolon, I am cutting the mesocolon towards the until the colon, until the transaction point. So entire colon needs to be bared circumferentially before we can apply the stapler. See, these branches here, they go and divide into smaller terminal branches. Sometimes these branches also can be as thick as the middle colic. So if it is a thick branch, you need to clip and cut. If it's a small branch, you can use a harmonic or ligature and cut. You can see the colon, wall of the colon there. So along the wall, the dissection will proceed. The aim is to circumferentially clear. See this vessel, this is a small vessel, so I can, if it's a larger vessel, I would clip and cut it. It is better at one point to identify the wall and then trace along the wall, so that you will not lose the plane. And you can stick to one circumferential plane and not lose the plane at different levels. So whatever can be done from one side, it will continue, and some part of it have to be done from the supracolic compartment, almost reaching the opposite side.
Sorry to disturb, sir. I have one question, sir.
Yes?
Sir, how will you decide the point of transaction, sir?
Point of transaction, extended right hemicolit, 2/3 of the colon will remove, or right colon. And again, we'll have to see where the middle colic left branch is going. So we need to trace along that one and then cut.
Thank you, sir. We find any vascular injury at the early phase of dissection, sir? How to
At which point? Where?
At the
Which point?
early dissection only, if we injure the vasculature, then how to...
Vascular injury can happen at any level. We have to repair it. Superior mesenteric vein, you can repair it. Artery, don't try and don't damage it.
SMV
Gastrocolic,
injury, superior mesenteric vein injury, sir?
we can repair that. This is the head of the pancreas. The remaining part we are separating from the mesocolon. As we go ascend upwards, there is duodenum. D1 part is coming into the picture. We have to be very careful. Easy to damage duodenum at this point. See, most of the head of the pancreas is separated. Whatever can be separated, separate from here. Rest of the part is easy. When we reflect the colon from the supracolic compartment, it is easy to dissect off the rest of the part from there. That you will see now. So now what I am doing, I am going to the supracolic compartment. So I need to reflect the omentum inferiorly, take the colon down, and then create the window between the greater curvature and the stomach, and go along that line towards the hepatic flexure. So for this case, the right left hypochondral port traction port was slightly coming in the way of the dissection. So I decided to add one more port for traction of the stomach. Here it will be coming from the opposite direction and it will not be hitting my hand. So the assistant sister has given traction here. and the suprapubic port, one instrument will be put, and the colon will be given traction from below. So this one momentum in between will get nicely tented. Here ligashore is a good instrument to use. It's easy to get lost in these planes because they all look the same. So slowly we have to start releasing. You can see the gastroepiploic vessel there. We already clipped the gastrocolic trunk from below. So slightly separate the tissues and then do the sharp cut. Now I told you it will be easy if we have reached the hepatic flexure from below. You will know why in a few seconds time. Here even gallbladder was slightly adherent to the transverse colon. It's easily released. If you have a good traction below, it's easy to work. Below the level where I am working will be the duodenum, so you have to be careful when going depth. That is why go layer by layer. Initially it looked like a big vessel. I was thinking I may have to clip it. But once that tissues around it are released, it was a pretty okay vessel, so okay with harmonic to cut. So I gave a short Poisson harmonic on two sides, and in between I cut the vessel. Now you can see the slowly the layers are opening up. See the gauze which was kept over there, it is visible now. After the dissection is done, what we do here is keep the gauze near the D1. So when we approach this, we can see the gauze next to the duodenum itself. So that way, another way of protecting the duodenum part 1 when we are doing the supracolic dissection. So this is the opening which I had already done from IRITA technique. So now from here it is easy to trace and finish the dissection. Lateral wall, I'm going to keep it intact, and that will be the last part of the dissection, because once if you release the complete lateral wall, it will fall into the operating field. The entire tumor and the colon will fall into the operating field, and then it will be slightly difficult to handle that. So leave it as it is until all the anastomosis, everything is done, and then we can release it. That depends on what kind of anastomosis. When it comes to that, I will explain why. Now you see the head of the pancreas, duodenum, and these vessels are already clipped from below. All this nodal clearance have to be given. See, already clipped below. So now I can confidently separate those tissues. This is the complete colonic transaction. You can see all the clips in its place. Now the colon from the omentum I am separating it because we need to reach the other side for completion of transaction and bearing of the from the inferior side. We had started clearing the mesocolon from the superiorly. That last part is remaining. That has to approach there. We need to make a window here near the transaction point, and all the omentum will come along with that one. Release this a little more because when we are doing the anastomosis, it will not come into the operating field. So I generally release this part which is supposed to be transacted out, slightly release from the colon. So it will fall away from the operating field. Or when we are later, when we are tenting it, it will be coming in the way. The momentum is getting transacted. The right part will come out completely along with the specimen. Don't give too much of traction when using harmonic and these fatty tissues because sometimes it will not coagulate well before it's getting cut. So keep the traction to slightly relax the traction when cutting it. So that way it will seal the vessels well. We need to clear the remaining part of the mesocolon and prepare the area for placement of the staplers. Go along the wall of the colon and separate all the tissues. Now we can see it's circumferentially we have cleared. When we completely clear like this, a nice line of demarcation generally develops. Now next we have to separate our mesentery from the terminal ileum. A minimum of 10 centimeters have to be removed along with the specimen. Again in this location, don't give excess traction. If you have a ligature, it is better. It will give a nice coagulation here. go until the wall of the ileum. Ideally, one more traction coming from either the right or the left hypochondrium would have been better, which we'll see now. This traction a fraction earlier would have been better. I felt I required few more extra centimeters of terminal ileum to be taken out. So I go till the ileal wall. Automatically after this step, the transaction point develops there. So next step will come is the anastomosis. What to do for the anastomosis? You can put a midline small incision, retrieve the entire specimen out, and with the 80 and 100 stapler, you can do a T-shaped anastomosis. That was the one generally and commonly which is being done. From there, we have gradually now shifted to intracorporeal anastomosis. Again, in intracorporeal anastomosis, there are small changes in techniques to be done. One is, you are seeing the transverse colon. You can apply a 13 mm, 12 mm port and transact the transverse colon. And then, with another stapler, transact the ileum. Put a phalansteal incision, remove the entire specimen out. And then, take this ileum and the colon, place them adjacent to each other, then apply a stapler through that one, and that rent being closed by sutures with an absorbable suture. That is one technique. Another technique is the same thing to be done until this step, except the rent can be closed with another stapler by putting along the tangentially along the anastomotic line. That is another technique of intracorporeal anastomosis. The third technique is what of lately I have been trying out to see how the results are. This is technique, instead of using 3 staplers, I will be using 4 staplers. So the way you do a T anastomosis in open like that, same way I have placed the ileum adjacent to the transverse colon. Now I will be making a small rent in the tinea and in the ileum. First I am placing the bowel in its location so that it doesn't fall off, and my work should be easy. I am placing the 12 mm port in the right iliac fossa and then making a small rent in the tinea. The left hand slightly open it and do the same procedure on the ileum. Now where I have taken the suture is, if you see at the line of demarcation, just proximal to the line of demarcation, I have taken the suture, so that by the time when the stapler, when I apply the final stapler, it should be on this side of the opening. Don't take it too proximally, so that when you put the stapler, the line of demarcation should not be in the stapler. It should be well in the pink area. At this point, if you have an ICG machine, it is good because it will nicely give you the line of demarcation. So with that, I have taken a endo stapler 60. This is a purple tri-stapler. Then slide the colon and the ileum along with that. Make sure that they are sitting nice horizontal, parallel to each other. You can see now it's sitting properly. If you require, do final adjustments. Ideally, the staple line coming on a tinea is a very good thing to have. Now you see it's sitting parallel to each other. Just a slight final adjustment and then it's good to go. Now once this stapler applied, if at this point you can apply a T stapler, but the problem is the anastomotic site can become a bit narrow. So what modifications I have done is applying one more stapler through this stapler so that the anastomosis become white. So it will not matter at that time whether it's a antiperistaltic or properistaltic. So through the same opening until the bifurcation of the previous stapler and applying second stapler. So 62 staplers have applied. See now difference between intracorporeal and extracorporeal is one, we are putting the incision in the upper abdomen where the pain is higher, lower abdomen pain is tend to be slightly lower. Recurrence chances of hernia is slightly higher in the upper abdomen. So that way phalansteal incision is far better. So that way one way this intracorporeal is better. Second is time to first passage of the flatus, recovery time, passage of bowel, everything is slightly faster in intracorporeal anastomosis. And plus the incision is in the lower abdomen, of course, the pain is also lesser. One suture in the midline is also enough for this, but I generally take two so that it will keep the anastomotic site that line in one plane. I'm going to park the needle somewhere in the abdominal wall, and our assistant will hold until required. And then again I've taken a tri-stapler here, 60 purple. And then along the transaction line, the previous I had showed, circumferentially I had transacted. Through along that line, I'm passing this. Sometimes if the colon width is smaller, there are at least two cases where with a single stapler, we have completely covered this. But in general, it will require at least two stapler, 160 and 145 or 260. I don't mind if a bit of the ileal mesentery or this comes along with that one. So at least I'll be happy with respect to the blood supply. Anyway, I'm using two staplers, so little bit of extra mesentery is always a bonus. So once the stapler is applied, you can see the nice transaction line and tri-stapler. 3 lines of staple lines are there. Need to straighten this, then close and then remove it. So at this point, you see the remaining pedicle is small. So if you have a 45, you can apply a 45, or 60 if you have, you apply 60. Make sure that the transaction line, that staple correctly sits in between, not to have two different transaction lines. You should see the distal tip empty at the end of the stapler line, or else you will end up using one more stapler. So nicely come until the bifurcation before applying the stapler. Check inferiorly and superiorly also to make sure no other structures have got entangled in the stapler. Applying you can see the blade running through and then the transaction gets completed.
Any question they are asked in that?
So after this step, you can see there is no bleeding at all, nicely stapled. But then we have 2 or 3 cases where we have seen the patient having intracorporeal bleeding for a few days. So that is why we do a suture line, run one more run, we do on that one. Now to remove the specimen out, if colon and ileum is connected, then you have to do a bigger incision. So disconnect them and close the openings. So that way you can make a smaller incision just adequate for the tumor to come out. Nicely close the opening. So once this step is completed, anastomotic site is overrun, not from completely from the intention of anastomotic leak, but more of also intention as to prevent any bleed inside. Because the colon wall is thick, even then there is small chance of intracorporeal bleed. So this most of the cases we have not had intracorporeal bleed occasionally, except a case or two. This is the same procedure we follow in extracorporeal anastomosis. So you can take a barb suture here, or you can take a plain PDS 20. It's your convenience.
Okay, we'll comment off. We'll comment off. Okay.
Hello, sir. Abhay here, sir.
Yes, man. Tell.
Sir, in this anti-peristaltic, isoperistaltic, is there any difference, sir, in post-op bowel recovery, bowel trip function,
Nothing.
or is
See,
it the same? No difference.
no difference, man. Because see, we are anastomosis is small, means it may make difference. In this colon cases, it will not make much of a difference. And plus, if you see the anastomosis, what I've done is quite wide, nearly almost 8-10 centimeters wide. So it's not going to really make much difference.
Okay.
Sir,
Sir, Kalim here, sir.
Yes.
Sir, how much size should be there, at least minimum size for enterotomy size in the
For
anastomosis? In the anastomosis, how much maybe the minimum size should be there, sir?
minimum
Like
of
you
4
told-
centimeters should be there ideally. Minimum of 4. That is when stool, all those things will nicely pass. Lesser than that, it will become narrowed.
Okay.
So if you apply a 6 centimeter stapler, only one stapler, and then for transaction, if I apply one stapler, the anastomotic size will come exactly to 4 centimeters, which is
Around.
generally adequate. But if you miss a few millimeters here or there, thickened bowel or something, you will end up causing narrowing. That is why I use 2 staplers so as to not to cause that. If you are going to go put a stapler and close the suture, close the rent with the suture, then only one stapler is enough, because you are closing the stapler, entire 6 centimeters is available. But because here I am using a transaction one more T stapler, so slightly a wider anastomosis would be better. Till now, with this particular technique, we have had 0 leaks. One patient had the intracorporeal bleed of the entire thing series we have done. So we are going to see the results in some time when we publish the data of this. This stitch is taken so as to not to cause pressure on the anastomotic site. Robotic lap wise, if you see, thing is, if it is a very straightforward case, you may not find, because you are sticking to the surgical planes. But the way you do the surgery and go through the planes, I would feel, even though not most of the studies showed not much significant, I feel robotic wise, generally what I've seen, the lymph node, all those things have been slightly higher. from the pathology report. Of course, there can be variation based on how the testing is done. Barring that, it's just the precision of the surgery, getting close by, stable camera. See, when we do this comparison, we'll only be seeing the final result of that. We will not be seeing what is the effort taken, how did we go through the planes, was it good for the surgeon also. All those things will come into the matter. But overall, if we see, for my personal, even though not much supported data, difficult to tell one different from the other. But any given day, these procedures I would prefer to do robotic than lab. Classical data wise, you may not find much difference. So after the entire procedure is done, finally I am releasing the lateral wall. So until now, this was holding the tumor in its place and not allowing it to fall into the operating field. So once everything is done, I'm going to release this.
Sir, Siddiq, sir.
Yeah.
Sir, what added advantage you noticed with IRITA technique when compared to other techniques, sir?
See, one thing is in IRITA technique, there have been for example, in robotic technique, when it was studied that caudal to cranial technique, they have shown that there is slightly more lymph node harvest in this technique. One. Second thing is, we would have already lifted the mesocolon from below before going to the vessels. So that way the duodenum is safeguarded. So these two, there are advantages of going in IRITA technique.
Okay, sir.
Once final listing is done, we give a last wash. And for straightforward right hemicolectomies are extended, most of this anterior section, we don't place the drain unless it is required. If any deviation intraoperatively or if any other indication from the patient side is there, we place the drain. This patient, we did not place the drain. By I think for fifth day or so, he got discharged. By third day, he would have shifted to semi-solid to normal diet. Most important part at the end of it, port closure for the 12 mm port. So now I place the omentum over the anastomotic site and I leave it like that only. Now you can see the C loop of the duodenum, pancreas, superior mesenteric vein, and all the nodal clearance, complete D3, CMV, CVL. Basically, it's the same thing. So complete clearance has been given. Don't forget to close the port. 10 mm and 12 mm both have to be closed, port closures. Yes, thank you. Any other questions? We'll take it.
Sir, in obese patient, if is there any difference in the technique, sir?
No, we follow the same technique. Only thing is they tend to have a bit of paniculitis. So that time when we are dissecting along the vessel, you may find the fat is a bit adhere to the vessel. So that time better not to try to get into the adventitia and do the dissection. Just stay lateral to the vessel and ascend upwards superiorly. And of course, the second thing is the bowel tend to fall into the operating field a bit more often in obese patients. But then with if you take extra port and give the traction, that should not be a problem. Even if you find it is very difficult to approach, then you do the medial to lateral approach. That time the bowel will be reflected downwards. Directly approach the vessel first. From medial to lateral side you can go if it is that difficult to approach from IRITA. But till now we have done so many obese patients, we never had any problem, barring occasionally the bowel loops slightly coming into the field of vision.
Okay. Sir, for Crohn's, when we plan for a right hemicolectomy and a malignancy, how do we approach that? How's the difference, sir, in the technique? Does
We
the
don't need to go D3 that time. We are not going for nodal clearance for Crohn's, no. the indication will be completely different. So that time you have to consider whether you have to put a stoma or not in Crohn's patients. In this one, you are going to go to the vessels and clear the nodal tissue because that is where the main problem lies for the tumor. But whereas for Crohn's, you are only removing the this one. What is it? The colon. Nodal clearance will not be of that importance that time. You can go D2 and then complete the dissection and then have to consider whether to put stoma or not for those patients, depending on the severity of the condition.
Okay.
Sir, D1 also.
Sir, D1 also we can go for Crohn's
Which
disease.
one? Yeah, you can go
D1
for
also we
Crohn's.
can
It's
go
not
for.
a problem.
Crohn's disease, depending upon the newer concept is the diseased mesentery has to be removed. So mainly if you are doing ileocecal Crohn's, so you have to take the patient when there is not much of active Crohn's disease. So we have to give medical treatment. You have the optimal time of intervening for Crohn's is very important. So in that time, see after going in wherever the diseased mesentery is there, that has to be removed. As he said, we cannot go for a D3 lymphodectomy. So like a D2, along with that diseased mesentery has to be removed. And if the patient is under control, we need not have any stoma. But you have to be very careful. So particularly for ileocecal Crohn, not for other Crohn. Small bowel Crohn's different. Okay. And this IRITA technique, what we have found is we are releasing the superior mesenteric vessel from the retrograde attachment. So even with the mild traction, the bleeding is reduced. That was the main advantage of our IV tracking. So initially itself, we are releasing the root of the mesentery. So mainly from the SMB. So when you do without this technique, main thing as I said, from caudal to cranial, we are releasing this and we are first safeguarding the retrograde structures, that is the ureter, goiter vessels, and the main thing is duodenum. So if you are going directly from mediator, there is high chance you will not be identifying the duodenum, you may injure the duodenum. And of course, we are not safeguarding the ureter and goiter vessels. Another thing, the superior mesenteric veil root is not released, that is, it is not giving away. So the yielding is be there. So whenever there is a traction, the mild traction also there it can bleed, particularly from the gastrocolic trunk. So that's why now we are slowly modifying with our IRITA technique. Following the IRITA, before going the ileocolic, we go up and just control the gastrocolic vein. So Harish has nicely shown the D3 lymphodectomy, which is actually, as I told the recent papers, doing a right hemicolectomy by a CMA is highly challenging. So experienced surgeons only do without bleeding, and bleeding is the main problem they have come across all these studies. So they are giving more importance. That's why I've been talking about the bleeding at the last time. So to control the bleeding is where it is coming from the branches of gastrocolic trunk. So as you said, most of the time, ileocolic artery and vein will be tackled nicely. But following that, while approaching the middle colic vessels, then because it is coming behind, so you will not be saying from here if you are approaching, it is in the another layer, the gastrocolic trunk. So there is so much of variations there. So if you can tackle that first, then you are coming from the typical ileocolic from the IRITA technique, then bleeding is not at all there and you need not be afraid. And as I said, not all, each patient will vary depending upon the anatomy. Now he was development address is there, whether the obesity is there, whether the mesentery is with the inflammation or paniculitis, you should be very careful. So identifying the SMA, there are various steps, and each step you have to give importance. And you should be aware of the variation of the right colic vein and the artery. And sometimes if arteries are coming over the SMV, so while they are dissecting the SMV, you may injure the ileocolic vessels and the artery also. So you should be very careful. Is there any more questions has been? The time taken for this procedure, I think nearly 3.5 hours, I feel. Of course, if you are going for intracorporeal anastomosis, there will be a little bit more time. So extra half an hour will be there. Choosing intracorporeal, any pros and cons? I think fully he has discussed what are the pros and cons of extracorporeal, intracorporeal. Nicely he has mentioned. If you are going for intracorporeal, what the main advantage is post-operative incision hernia will be less because you are making the incision and in the suprapubic region. That's why. But many Japanese and Chinese, they don't bother. But still, there are for advantage and disadvantage. Of course, if you want to give all the advantage for the minimal access surgery, then you go for intracorporeal anastomosis, particularly in young patients. Yes.
But till now we never had a leak, no sir? Good.
No.
Intracorporeal we never had.
Intracorporeal we never had, but we had a bleeding. So most of the bleeding, as he said, all the intracorporeal anastomosis we have a bleeding, but all the bleeding we have managed conservatively. Only one case we have to go in and open, and we have to suture, and we have to open the anastomosis, control the bleeding, then we have to re-anastomosis. But so far all this conservative management. And one patient we have to do a colonoscopy and just give a hemostatic powder for controlling bleeding. So that because of that bleeding, we have to prolong his hospital stay. That is the one we have come across. That's why nowadays previously we are having only double stapling. Now we have a tri-stapling. That is very useful because we don't know. So all these will depends upon the patient. If we have a patient like old fellow, we have a chronic. He's taking chronic antiplatelet, clopidogrel with aspirin. So these are the patients post-operative. I mean, after surgery, whatever they may have bleeding. Our patient may have exposed to chronic steroids intake, yes, and previously exposed to radiotherapy, or previously they have exposed to chemotherapy. All these patients, you can expect whatever surgery you do, you can have a bleeding unexplained. Yes, probably the clotting. Even though we have do all the coagulation performance normal, still they may have bleeding. And particularly IBD patients, definitely they have. So I have a patient operated for Crohn's. Twice I have to go for the bleeding. Then at last we have to keep a stoma for the patient even after doing hemicolectomies for Crohn's patient because of bleeding. So like that it will be there. So depending upon the patient you can, but all this, if the patient is having following what I told, you should be careful. That's why we are doing a overrunning of the stapling anastomosis. Any question? Learning, the question they have asked, learning for right hemicolectomy. So that is the main thing. Now the concept in 2024 they have done. So previously for the early colorectal surgeons, the beginners, they used to do the right hemicolectomy. So now the concept have changed after the 2007. So after the concept of CAB, CVL or D3 nephrectomy, the learning curve has increased, and all these people, they have come across bleeding while doing the surgery. That was the main reason for the conversion to open. So the learning curve is increased for the present CMF, the right hemicolectomy. Previously, you can say like 10 cases even. Now we can say 20 cases, but it depends upon how your mentor, with whom you are having a mentorship, or from who you are learning. At least for any cases, I would say like 20 to 30 cases. So post-operative tube, as he already told, we are following the ERAS for all our colorectal surgeries. Usually, these patients will have they will be removed everything, rise to everything on the even without rise to, they will be sending to the ICU. But one day on the day of surgery they will be in ICU. Next day, patient will be in the ward, and all the tubes will be removed, including the right tube and urinary catheter, and they will be starting liquid diet in the day 1. And usually day 2 or day 3 they will be taking soft diet or semi-solid, and 4th day they will be discharged. But unless the patient is having some ileus, they may be extended to the 5th day. But average right hemicolectomy patient will be 4th post-operative day, they will be discharged. But as I told, depending upon the patient condition, any comorbidity is there, chronic, any chronic comorbidity is there, patient with old age, the autonomic neuropathy, then what we have found after this D3 lymphdectomy, because we are going close to the vessels, there may be autonomic neuropathy, particularly in the old age, chronic, long-standing diabetic patient. These patients, they go for an autonomic neuropathy. So we may have to give some prokinetic. The length of hospital is delayed for 1 or 2 days because of that ileus. Otherwise, other than this bleeding and ileus, all these patients will be discharged on the fourth puberty, most of the time. And now most of the patients will be having a drain. All these patients, some patients, if you have a lymph extensive because of dissection, they're having some lymph, a few patients we have, so we have to keep a drain for a long time, or we cut and put a bag and we send with the drain, some patients. But without drain patient also not much difference, but most of the patients will have a drain. But all this drain will be removed on for a third day and they will be discharged fourth day. Any more questions? Okay, if there is no question, I think we can go to the next topic, perioperative chemotherapy. I think is there a? Okay. So next we'll go to the topic that role of perioperative chemotherapy in colon cancer.
Yes, sir. Good evening, sir.
Muthulingesh, you are ready. Okay.
Yes, sir. Yes, sir. I'm there, sir.
So Muthulingesh is our medical oncologist. He has a vast experience in treating patients with colon rectal cancer. And now, what is the recent concept in neoadjuvant chemotherapy or post-op adjuvant chemotherapy in colon cancer? Yes. Over to you.
Yes, sir. One. Good evening, sir. So, good evening, everyone. So, I thank SRP sir for providing the opportunity to present in this platform. So, I'll be mainly discussing the adjuvant systemic therapy in colon cancer. So the scope of the session, so we'll be discussing initially the stage 2 colon cancer, proficient MMR and deficient MMR, and stage 3 proficient MMR and deficient MMR. And there is a recent data on role of exercise post-adjuvant therapy that we will be discussing at the last. So in this way we manage colon cancer. So to start with, we'll be discussing in the MDT. We'll be reviewing the diagnosis and staging, and followed by surgical resection, and then we'll be again discussing in the MDT for the post-operative histology, plus or minus MSI status. But currently it should be plus MSI status even in stage 2 and stage 3 colon cancer. So that the importance will be discussed in further slides, and then followed by adjuvant chemo, followed by follow-up. So why adjuvant therapy? So survival with surgery alone, we can see in stage 1 it is a 5-year survival of 85 to 95%. In stage 2 it is 60 to 80%, and stage 3 30 to 60%. So we need to add something else along with the surgery to improve the survival. So we can see the prognosis. Even in stage 2, we have a spectrum. T3N0 is there, T4A N0 is there, T4B N0 is there. So in that way, we divide it as 2A, 2B, and 2C. So even in stage 2, we can see that T4B N0 patients doesn't do well, and they have a poor prognosis. But we say it as stage 2 because it is N0. So once it is N plus, it is stage 3. Stage 3 again we divide into low risk and high risk, so that we will be discussing it in further slides. So the benefit of adjuvant chemotherapy, so the benefit have been most clearly demonstrated in stage 3 node positive disease that we all must be knowing. So in stage 3, there is 30% reduction in the risk of recurrence by adding chemotherapy to surgery, and even 22 to 32% relative reduction in the mortality. But the benefit of chemotherapy in stage 2 node negative disease is still less certain. So chemotherapy in this group is variable. Now the role of chemotherapy in this particular stage 2 is evolving. So all patients in stage 2 and stage 3 colon should be tested. We are anyway having the institution protocol of doing MMR testing for all patients. So we should be testing either by IHC MMR, or it should be by MSI testing by PCR or NGS. So first we will be discussing stage 2 colon cancer. So as I told before, the prognostic stage group, we can see that it is 2A, 2B, 2C. It depends on T stage, whether it is T3 or T4A or T4B. So for patients with 2A, so in stage 2, what are the indications for adjuvant therapy? So probably most commonly we are seeing more T3N0 patients. Usually it is 2A. So we will be testing the MMR status. First we have to test the MMR status, and the patient, if the patient is having proficient MMR, that is there is no loss of expression of MMR proteins, then you should be seeing the risk features. High risk features as listed down, we can see that these are the high risk features: inadequate lymph node dissection, which is less than 12 lymph nodes dissected, or a perineural or a lymphovascular invasion, or a poorly differentiated or undifferentiated histology, clinical bowel obstruction, perforation, and grade 3 tumor bedding. These are the high risk features which has been shown that they have a high risk of recurrence. So whenever there is a T3N0 patient also, say stage 2A, after testing MMR, if it is a proficient MMR, we should be checking any of these high risk features are there or not. If the patient doesn't have any of these high risk features in a T3N0, they are said to be a low risk patients, and we can offer observation rather than adjuvant chemotherapy for such patients. If the patients are having 2B or 2C disease, say PT4, it can be a T4A or T4B disease. Again, we have to go through all these high risk features, whether any risk features are there or not. So basically, it is clinico-pathological features. If there are two or more high risk features among these listed features, then adjuvant therapy is recommended for those patients, those stage 2 patients. So if it is a T4 disease, straightforward, even a one clinico-pathological feature, that is T4, is good enough to discuss about the risk and benefit of adjuvant chemotherapy. If it's a T4B disease, definitely we have to discuss the risk and benefits, and then we have to proceed with chemotherapy. If it is T4A disease, then again you look into these features, and two or more risk features are there, then adjuvant therapy is recommended. So we can see that what is high risk. Different expert groups are giving us different, it is almost the same features. You can see, in addition to what all we discussed, T4, inadequate lymph nodes less than 12, poorly differentiated, perforation, clinical obstruction, LVI, PNI, all these are common among all these three expert groups, NCCN, ASCO, and ESMO. One more additional feature, which is high preoperative levels of serum CEA, which is added in the ESMO expert group. So apart from that, otherwise it all looks into the similar clinical features, and they are categorizing as high risk stage 2 if the patient is having more than or equal to two features. So what is the benefit which we get by giving adjuvant therapy in stage 2? So we have a systematic review and meta-analysis which has included 23 studies, cohort studies, and one RCT, which is a mosaic trial, which is a landmark trial. So we have data to say that in stage 2 high risk patients, those who have that high risk features, they benefit with addition of chemotherapy with a hazard ratio of 0.64. So, and then final subgroup analysis has shown that the benefit is limited to those patients who are having perforation, obstruction, T4 lesions, and inadequate lymph node dissection. So from these data, we are bringing all the guidelines to recommend the adjuvant chemotherapy. So we can see that T4 primary in a resected T4N0, actually they have worse prognosis than even a stage 3A disease. So those kind of patients has to be considered as high risk, and adjuvant therapy should be offered. So fewer than 12 lymph nodes also across 4 studies of 6,800 patients, there was a positive effect of adjuvant chemotherapy was found in those patients inadequately dissected. And obstruction and other risk factors also has been shown that there is significant benefit with adjuvant chemotherapy. So in PMMR, in proficient MMR stage 2, what regimen is recommended usually? So it all started with the leucovorin 5FU or a capecitabine rather than oxaliplatin based regimen for most of the patients who are having a low risk disease. In some low risk, we will be avoiding and we will be putting on observation. If the patient is having just one risk factor, then you may offer a single agent capecitabine for a period of 6 months rather than considering oxaliplatin based chemotherapy for those patients. But for those patients who are high risk stage 2, who are having 2 or more risk factors which has been listed already, or either a T4A or T4B disease, or more than 3 or multiple high risk factors, we have to discuss the potential benefits and risk of oxaliplatin combination with capecitabine. Either a capecitabine with oxaliplatin capox or a folfox has to be recommended for those high risk stage 2 patients. So in stage 2, so we are dividing into proficient MMR and deficient MMR. So in deficient MMR, we know that 5 to 15% of CRCs have a sporadic or inherited deficiency of DNA mismatch repair. So patients with deficient MMR have approximately, they are having a good prognosis, and they have a lesser risk of recurrence and relatively a higher survival rate after even surgery alone compared to the patients who are having proficient MMR. So basically, deficient MMR patient, they do very well without even chemotherapy in a low risk situation, in even a N0, T3 or T4. Even NCCN doesn't recommend chemotherapy for T4A disease for a deficient MMR status. For even T4B disease, they say either observation or adjuvant chemotherapy for 6 months. This is optional. We have to discuss between the benefit and side effects. It should be a shared decision making between the individualized patient decision. So, and then MMR status becomes the important predictor of benefit of 5FU based adjuvant chemotherapy. So usually, why we are doing deficient MMR tumors, usually they are resistant to capecitabine or 5FU chemotherapy, but they retain sensitivity to oxaliplatin. So whenever, if we consider chemotherapy for a deficient MMR patient, it should not be a single agent capecitabine. It should be always the combination of capecitabine plus oxaliplatin or a folfox regimen. So that is the reason we don't give a only capecitabine in case of deficient MMR patients. So, what are the indications of adjuvant therapy in deficient MMR stage 2? In proficient MMR, we said based on the high risk features. Again, here also based on the high risk features. Without high risk features, you just observe the patient rather than adjuvant chemotherapy. With high risk features, again, all those T4, obstruction, perforation, fewer than 12 lymph nodes, LVA or PNI, still the role of chemotherapy is uncertain in these deficient MMR population. We can even avoid in T4A disease in a stage 2 colon cancer. So further decision based on high number of high risk features, overall medical condition. If the patient is young, then you offer chemotherapy in such patients. So even if we offer some chemotherapy for a stage 2, it should not be a single agent capecitabine again. So it should be a capox or a folfox even in the stage 2 with the high risk features, deficient MMR colon cancer. So this is a flow diagram which can explain easily to understand the management of stage 2. So whenever there is a stage 2 colon cancer, you just have to do a MMR status. If it is deficient MMR, so MSI is high. So see the risk factors. If it is at least there are one high risk clinical pathological feature, then you again discuss the risk and benefits of chemotherapy. If at all chemotherapy is chosen, then 3 or 6 months of ox containing chemotherapy should be recommended, not a single agent capecitabine. Otherwise, if the patient doesn't have any high risk feature, then go for observation. No adjuvant therapy is recommended for those patients. If the patient is having a proficient MMR, then you look into the features as we discussed, like primary T4 or not, whether they are having 2 or more high risk features. Then you go for adjuvant chemotherapy. If there are no high risk features, then only high risk feature, still you discuss the benefit and risk, and then you consider even single agent capecitabine also. If the patient is not having any high risk feature, then you go for adjuvant therapy. So this is the basic, this is the data mosaic study based on which we are currently following the adjuvant chemotherapy, whether oxaliplatin addition has improved survival or not. So basically, it all started with only leucovorin 5FU. Then adding oxaliplatin has shown benefit in a major phase 3 trial, which is again a mosaic study, is one of the landmark study, where we can see the survival benefit. In stage 2, there is no much benefit by adding oxaliplatin. In stage 3, we can see that there is 4.2% benefit in survival by adding oxaliplatin along with 5FU. So we can see that based on the nodal status, if it is N1 on up to 3 nodes or more than 3 lymph nodes, we can see the difference. As the nodal burden goes up, the benefit of chemotherapy is higher, and the patient's recurrence rates are significantly coming down, and they survive better. And then this is a data Zeloxa, which has studied Zelox versus only 5FU. So as Mosaic compared Folfox versus 5FU leucovorin, this is the data for Zelox versus 5FU leucovorin. Again, we can see that adding oxaliplatin with capecitabine has improved overall survival. We can see that in longer follow-up, there was around 7% survival benefit, which was found with Zelox regimen, comparing only 5FU leucovorin. So next thing we'll discuss is how long we have to give chemotherapy. So some patients we are giving 3 months, some patients we are giving 6 months. How to decide that? So the effect of duration of chemotherapy, this idea collaboration data came. This is a pooled analysis of 6 randomized phase 3 trials, where they have kept the 3-year DFS as the primary endpoint with a median follow-ups of 72 months. They found that for low risk patients, 3 months of adjuvant therapy is acceptable. So who are a low risk patient? It should be a T1 to T3 disease or a N1 disease. They are low risk, and they 3 months of adjuvant therapy is sufficient enough. And in high risk patients, T4 or N2 disease, 6 months is always preferred. So then they found the another interesting thing: 3 months versus 6 months. What about the regimen? If you choose Kpox, 3 months can be used as alternative for 6 months, which means 3 months was found to be non-inferior to 6 months. So we can even give only 3 months of Kpox in a low risk stage 3 patients. But if you choose Folfox, 3 months was found inferior to 6 months. So we will be explaining both the options to the patients. If the patient want to choose Folfox, then we will be giving it for 6 months. If the patient can opt for Kpox, we can even finish in the 3 months period for a low risk stage 3 patients. So this is all for proficient MMR. Stage 3 patients, chemotherapy is the standard of care. Either 3 months or 6 months, we decide based on the risk, low risk or high risk, which is based on N1 or above. Then comes the data. This is the latest data. In stage 3 also, there is role of testing deficient MMR status. So if such patients are having dMMR, stage 3 nodal positive patients, they have done a study, which is atomic study, which is a phase 3 randomized study, which has compared addition of immunotherapy atezolizumab along with Folfox chemotherapy versus only Folfox. They have given for a period of 1 year of treatment. Atezo was continued for completion of 1 year. Folfox will be given for 6 months. So in this study, interestingly, they have found that by addition of immunotherapy along with chemotherapy in a stage 3 deficient MMR colon, it has improved significantly the DFS, which is 86% versus 76%, which is a significant jump. It was statistically significant, which is recently presented in the ASCO this year. and this has been added in the NCCN guidelines as well. So current recommendation for DMMR stage 3 colon, it is not only chemotherapy, we are adding immunotherapy along with chemotherapy for a period of 1 year. That significantly reduces the chance of recurrence and improves the survival. So we should be doing MMR testing for even stage 3 patients. Then comes the latest publication, again structured exercise after adjuvant chemotherapy for a colon cancer. Again, it was an interesting study, which is a phase 3 open label RCT, which was conducted in 55 centers, and patients with high risk stage 2 or a stage 3 colon cancer who are receiving adjuvant chemotherapy were included. So those patients after completion of chemotherapy were advised a 3-year structured exercise program versus only health education in the affected patients post chemotherapy. Interestingly, they have found that those 3 years of exercise program, structured exercise program in those patients, significantly reduced the recurrence rates, and you can see the DFS curves which are splitting, and significant number of recurrences have been reduced in these patients who are doing structured exercise for a period of 3 years post chemotherapy. We can see the DFS benefit, and we can see the incidences. All the recurrence rates have come down significantly in the exercise group comparing to only health education group. We can see even liver metastasis recurrences incidences has come down, and new primary cancer also has come down. Death number has come down. So overall, the events are lesser in the patients who are allocated in the exercise group. So finally, even the overall survival, we can see that structured exercise has impact in the survival of the patients post chemotherapy in a stage 2 high risk or a stage 3 colon cancer. So this is the latest data which was presented in the ASCO. So we can see that 5-year DFS, 8-year OS, all that we can see that the exercise group did very well. It is around 7% improvement, 6 to 7% improvement in DFS, and OS. You can see that 7% improvement in OS, which is a big number in a stage 3 colon cancer. And physical functioning is improved significantly in the exercise group. New cancers are reduced, liver recurrence rates are reduced, grade 3 events are reduced. Grade 3, of course, grade 3 events were little more in the exercise group, that we have to look into the full paper. Actually, it is not out yet. And musculoskeletal events also little more in the exercise group. So finally, so to conclude, in stage 3 colon cancer, always do a DMMR and MMR status. See whether it is a DMMR and whether the patient is for observation or chemotherapy in case of high features. If it is proficient MMR, again look into the high risk features. Based on the number of high risk features, 2 or more high risk features, then adjuvant therapy is recommended. In stage 3, again, adjuvant therapy is anyway recommended. Whether we are giving 3 months or 6 months, it depends on the risk, high risk or low risk. If it is N1 disease, it is low risk. We can even give only 3 months of Kpox or a 6 months of Folfox. If it is N2 disease onwards, the N2 or N3, then you give only you give 6 months of treatment, either Kpox or Folfox. And interestingly, in DMMR stage 3, again, addition of immunotherapy role has come recently. It is updated in the guidelines as well. And this latest exercise data is also interesting. We have to encourage all those patients for a regular physiotherapy, all that structured exercise pattern for a period of at least 3 years post treatment, so that it improves the survival. Yes. Thank you.
Thank you, Muthu,
Yes,
for
sir.
the nice, overall adjuvant therapy in colon cancer. But I
Yes, sir.
thought you would have touched the neoadjuvant for colon cancer also. That is a big thing. It's coming out.
Yes, sir. It is actually, it is not added in like, it has not come into the practice, but we can consider. Sir, actually, there are papers in operable colon cancer also. There are role of neoadjuvant. There is a phase 3 data, but giving a 6 weeks of chemotherapy, then taking
Yes,
up.
yes. In main inoperable or locally advanced colon cancer, you give chemotherapy, and they have a new paper has come. Even NCCN guidelines has given, if you have an inoperable or locally advanced colon cancer, you if the patient is non-obstructive, you go for a chemotherapy. Then they have shown the benefit overall survival, disease survival is benefited. You can even downstage and downstage the disease, downsize the disease. That is one important thing I want to think.
Yes, sir.
Two questions there is there. One thing is. Mostly you people are talking about stage 1, stage 2, stage 3 mostly, but usually we say it's a T3 and 0
Yes, sir.
MSI high.
Yes,
So
sir.
you go for, but we say this patient is having the obstructive features, we do. But after surgery, they said T3 and 0, then you said there is no feature that whether you can observe or not. But usually we think, okay, this is a patient, definitely post-operative patient will be taking, is a young fellow with
Yes,
the
sir.
obstruction, he has big tumor we have removed. But pathologists, they said all the, we like 40 lymph nodes negative, but it is only T3. But
Yes, sir.
we think it is only like a T4 lesion while doing the surgery, but most of the time it came because of the desmopathic reaction case. It is a T3 they will give.
Yes,
So
sir.
you go only with the pathology what they say. The chemotherapy will say okay only T3 and 0. But we know the importance of the tumor while doing surgery. This patient definitely should go for adjuvant chemo.
Yes,
But
sir.
after talking with that patient attendant, then you say okay you can observe or give only capstipid. So how you differentiate? We have to you discuss in the tumor board with the surgeon and the pathologist rather than only
Yes,
going.
sir. Always clinico-pathological, sir. We have to discuss the presentation, all that, sir, and intra-op findings. All that will be discussed, sir. It should be discussed, sir.
So in that case, T3 and 0 MSI like MMR proficient,
Yes,
you
sir.
go for a capstipin or axloplatin. But you have explained that depending upon the high risk, you go for a
If,
capax
if
or
there is
only
only one, if there is only one high risk feature, we can opt for a single agent capecitabine for 6 months, sir. That is sufficient, sir. If it is two or more, then we have to discuss both the options with the patient, sir. If the patient is fit enough and young, we can opt for a combination capox. If the patient is frail, then we can go for a single agent capecitabine in such cases, sir. Elderly patients and all, we are seeing more than 75 and all, sometimes they won't tolerate, then we choose accordingly, sir. Individualized decision.
Another question is you have diagnosed a patient with a CA colon. So before going for surgery, we are doing MSI, and
Yes,
if
sir.
come as MSI, that is MMR deficient. What is your approach? NCCN says something you can go for a like checkpoint inhibitor directly without surgery, or there is a role of surgery, or post-operative after surgery if you become MMR deficient. Whether you have told both combined chemo with biological
Yes,
or
sir.
only
Actually,
checkpoint inhibitors, or there
yes,
is
sir.
no role for checkpoint inhibitors.
Sir, currently, this role of upfront checkpoint inhibitor avoiding surgery, we are doing in rectum, sir. Rectum upfront, we can avoid surgery by adding immunotherapy combinations in upfront. We can
That is
just
easier
observe
as
them.
well for the rectum. Even for the colon, what is the current practice? I'm just
Sir,
asking.
in colon, it has not changed, sir. Current practice has not been changed. This adjuvant therapy also has not come just now, sir. In June only, this has come data. So we are not doing it currently in the practice, sir. Upfront surgery is advised always for colon, and then followed by we will add immunotherapy along with chemo, sir, based on the
So
stage.
post-operatively, MMR deficient, you are adding only the immunotherapy
Yes,
directly without plus chemo. So what I want to
plus
ask,
chemo.
whether
Yes.
you are just giving only the without chemo, only immunotherapy.
No, sir. No, sir. Combined, sir.
So
Because
any,
always N plus N2 disease stage 3 requires chemo as well, sir. Not immunotherapy alone. That data has not come, sir. For now, the data is mature for combination, sir. Chemo plus immunotherapy. So this is what they have studied, and we are.
that immunotherapy cost will be raised, and you said it's 1 year, it's a more. And the question is there, how will you tackle the chemotherapy toxicity? But it is a big question, but you can just tell in brief.
Sir,
Like,
if we see it, it starts with regimen, sir. It starts with regimen actually. Folfox is actually a little better tolerated than Capox, sir. Sometimes tablets, they have to take too many tablets, and then the side effect profile is little different, sir. With capecitabine, we see little more hand-foot syndrome, all that, and then neuropathy, all that, sir. But with Folfox, we see elderly patients also they tolerate well. But the issue is the logistics, sir. Again, 2 weekly once they have to come, and then they need a central venous.
But most patients they prefer only capox because
Yes, sir. They prefer K-Pox because logistics and
so
ease
they
in
come
take.
just few hours, then they go. So they don't want to come back again for this thing.
Yes,
But
sir.
as you said, for the past like 15, 20 years, we have been using only capox. Very few patients which they could not tolerate. Then we explain they go for a Folfax, and the cost effective for our particular our patients.
Yes, sir. Cost
Because
effective,
go for
definitely
Folfax,
K-Pox
every
is.
2 weeks they have to come and they for stay for a 3 days, four
Yes, sir.
days. Then the cost is more. So
Yes,
that
sir. The chemo port also required. Some
is
access is
yes.
required. PIC line or chemo port is required. All that is adding up the cost, sir. Now this atezolizumab in DMMR immunotherapy also 2 weekly once we have to give along with Folfox, sir. Either Kpox also we can add. The dosage is differ, but the thing is again cost, sir. Around if we give along with Kpox, atezolizumab cost is around 3.5 lakh, 3.8 lakh. But they provide some assistance, sir. If you buy for one cycle, another 2 cycles they'll give free. So for
You
three,
want to do for 1 year. You said for 1 year. That
yes,
means
sir,
how
yes, sir,
many
yes, sir.
cycle? So anything like that?
So,
Eight cycle or something like that?
sir, 3 weekly once, 1 year, it will be 17 cycles, sir. 17 cycles. So, along with chemo, 8 cycles they'll
So
take along
you
with.
expect more toxicity in that cases.
Actually, in that trial, sir, toxicity, there is obviously immune related toxicity is there, sir. But chemotherapy related toxicity, there is no much change, but immune toxicities are there. Of course, it is expected, sir, and it is not very high and all. When we combine with chemo, it is expected, sir. Whatever is expected, loose stools or skin reaction or liver toxicity.
Neuropathy. Neuropathy.
Yes, sir. Neuropathy is not much with immunotherapy addition, sir.
Yeah, okay. Chemotherapy.
Yes, sir. It is for
So what
chemotherapy.
what is your yeah, in case of adjuvant chemotherapy, if the surgeons find during surgery there is a cirrhotic liver, it was not direct pre-operative. During surgery, okay, cirrhotic liver. The post-operative, everything is like stage 2 disease or T3 and 0 and plus. How will you approach the chemotherapy in such patients?
So we'll be assessing the function, sir. Liver function,
So
how
that
is
case is normal.
LFT is normal. Oh, usually, capecitabine doesn't have much effect on liver, sir. Usually, it is renal clearance. So, if kidney is fine, capecitabine should be okay, sir. At least moderate liver function. Child pug B at least. Even with oxaliplatin also, child B we can do, sir. But child C, it is we have to.
Child A, but child A also
Yeah.
because but no paper is telling about the like 6 months.
They say it is not studied. They say it is not studied.
Because we are studying like that.
Yes, sir.
All the patients after chemotherapy, before going for ileostomy reversal and going seeing the liver,
Yes.
I can see obvious there is change because of the chemotherapy. Even the TNT patients also. So we are planning to have a study that we before TNT and post TNT, the long-standing effect of the chemotherapy on the liver,
Hmm.
whether the liver is going for early failure over a period of time.
Especially oxaliplatin can cause, sir.
Another question they have asked how to follow the cases following chemotherapy. So after finishing the cases, I mean following colon cancer, colectomy, hemicolectomies. So after adjuvant therapy, as we have discussed, all the patients will have follow-up every 3 months, first 2 years.
Yes, sir.
First, yeah. Then with the CEA, blood test CEA, ultrasound abdomen, and the X-ray chest.
Yes, sir.
And every year we'll be doing colonoscopy and CT scan abdomen chest screening.
Yes, sir. At least once a year.
Yeah.
Yes, sir. For
After 2 years, then every 6 months for the next 3 years. Like this, 5 years. After 5 years, every year, lifelong, they'll be coming for follow up with the.
yes, sir. Agree. Agree, sir. Yes, sir.
Okay, thank you, Muthu. I think we'll go to the next talk. I think Dr. Shankar is ready with the left hemicolectomy. So we have finished right hemicolectomy. Now we'll go to the left hemicolectomy. And left hemicolectomy is a bit tricky for the surgeons because the left colon is it not have a mesocolon. It is attached to the retroperitoneum. So if you want to do a left hemicolectomy, like a right hemicolectomy, transverse colon, sigmoid colon have a free mesentery. So the ascending colon and the left colon is attached to the retroperitoneum. So you have to remove the mesocolic attachment to the retroperitoneum to have a proper left hemicolectomy. That's why most of the time, depending upon the site, we may have to go for a subtotal colectomy rather than left hemicolectomy. Okay, over to Shankar now.
Sir, good evening, sir. Am I audible now?
Yes, yes.
Yes, sir. So, I'll be talking about left hemicolectomy today. So, before going on to discussion about hemicolectomy proper, it is important to understand the anatomy of the colon, specifically the vascular anatomy. The first picture it can be seen that the left side colon, being a derivative of the hindgut, is supplied by the branches of the inferior mesenteric artery in the form of left colic, sigmoid, and then it continues as the superior rectal or hemorrhoidal artery which supplies the rectum. So this is our area of concern. In addition to being supplied by inferior mesenteric artery, it also receives important tributaries from the superior mesenteric artery as well through collateral networks in the form of arc of Riolan and meandering artery of Moskowitz. Both these are vascular communications between the branches of superior mesenteric artery, usually the middle colic, and the branch of the inferior mesenteric, which is usually the left colic. However, there can be numerous variations in this arrangement. Also, another important collateral circulation to be considered is the marginal artery of Drummond, which is distributed along the mesenteric border of the colon, which share blood supply between the superior mesenteric and the inferior mesenteric. Collateralization happens at this level as well. In terms of venous anatomy, the main venous channels, namely the superior rectal, sigmoidal, and left colic vessels, join to form the inferior mesenteric vein. The inferior mesenteric vein eventually joins the splenic vein, usually, or sometimes it can join at the junction of the splenoportal confluence. There can be multiple variations in the anatomy of the inferior mesenteric vein. This is the basic anatomy that we encounter during left hemicolectomy. So there are three types of left colectomy to be considered. One is the standard left hemicolectomy, in which the origin of the left branch of the middle colic and the left colic artery is ligated at their respective origins. This is usually done for tumors that are present in the splenic flexure or proximal descending colon. This is the standard left colectomy. However, for lesions that are present little proximally in the transverse colon, that is mainly in the distal transverse colon, it may not be sufficient to take down only the left branch of middle colic artery. In such cases, it is important to take the middle colic artery at its origin in addition to left colic artery. This is extended left hemicolectomy. For lesions that are lying in the proximal sigmoid colon or distal descending colon, additional clearance is needed distally. So in such cases, inferior mesenteric artery is taken at its origin instead of left colic artery. So this is a formal left colectomy, total or formal left colectomy, where left branch of middle colic artery and the inferior mesenteric artery is ligated at its origin. So these are the three types of left colectomy. So coming to indications, left colectomy can be considered for both malignant as well as benign conditions. The common malignant conditions include malignancies of the splenic flexure, descending colon, proximal sigmoid colon, or the slightly more proximal distal transverse colon malignancies. For benign lesions, polyps that are present in splenic flexure, descending colon, proximal sigmoid colon, when they are not amenable for endoscopic polypectomy. And for other conditions like segmental Crohn's disease, where bowel preservation is of utmost importance, a segmental colectomy is preferred. So left colectomy can be done in such cases. Other conditions include ischemic stricture or diverticulitis predominantly affecting the descending colon. In all these cases, left colectomy can be done. So coming to the technique proper. So patient position, patient is placed in a low lithotomy or modified Lloyd-Davis position. And this is the standard port placement. Like anterior section, the port placement is similar. The camera port is a 10 mm port placed to the right of the umbilicus. And the right hand working port is placed in the right lower quadrant. It is a 5 mm port to begin with, later on changed to a 12 mm port while applying a stapler. And the left hand working port is placed in the right lumbar region. It's a 5 mm port. And 2 additional retracting ports are placed, one at the left subcostal and one at the left lumbar region. So this is a video of left hemicolectomy. After going in, first a survey is made to look for any metastatic deposits, any ascites. The liver surface is examined. And after that, the left side colon is retracted cranially, and the root of the sigmoid colon is incised, and the incision is taken towards the DJ flexure, towards the inferior mesenteric vein now. Near the DJ flexure, we identify the inferior mesenteric vein, which is skeletonized. Then we try to develop a plane below the superior rectal vessel, above the Toll's fascia. The inferior mesenteric vein is clipped close to the DJ flexure here. And here, in case of left hemicolectomy, the left colic vessel is clipped and divided. After the inferior mesenteric artery gives its branch to left colic, that is where it is divided. Here, further mobilization is continued laterally, preserving the Toll's fascia. Complete medial to lateral mobilization is done, safeguarding the ureter and the gonadal vessels that lie beneath the retroperitoneum. Once that is completed, we shift our attention towards lateral dissection, where the sigmoid and the descending colon is divided along the white line of Toll. Because it was previously completely mobilized from medial to lateral, the dissection laterally is very easy. Once we divide the white line of Toll, we are already into the previously dissected plane. And subsequently, like as we move up, we proceed towards the splenic flexure. And splenic flexure mobilization, generally, the previously clipped inferior mesenteric vein is only now being divided. Splenic flexure mobilization generally has to be done from all around, from below upwards, as well as from right to left. Here, the gastrocolic momentum is released from between the stomach and the liver, entering into the lesser sac. Gastrocolic the splenocolic attachments were released in the previous step. Finally, when the lower border of the pancreas is visualized, the root of the transverse mesocolon is released along the lower border of the pancreas, and the final attachments at the splenic flexure are divided. Here, once again, the inferior mesenteric vein is divided high up, close to the inferior border of the pancreas. Further attachments laterally are dissected. Once this is done, after the vessels are clipped, we look for the site of demarcation the bowel wall. Accordingly, we decide the site of transection. Here, the descending colon is the descending mesocolon is transected up to the level of transection. For an anastomosis in left hemicolectomy, it is important to mobilize the entire transverse colon and maybe even part of the ascending colon to facilitate reach of the transverse colon distally, especially when the transverse colon is not very redundant. It is important to mobilize. Here we can see that the transverse colon is being mobilized, being separated from the duodenum here. And now the hepatic flexure of the colon is being mobilized to facilitate a tension-free anastomosis, so that adequate mobilization is needed. Even the distal part of the ascending colon is being mobilized now. A check for hemostasis is being made, and now the transverse colon is being stapled. After once again deciding the site of division by looking for color change, or if ICG was used, that can also help guide us deciding the point of transection. Remaining attachments of the gastrocolic omentum are being divided. The previously marked site of transection of the descending colon is now divided with a linear endo-GIA linear stapler. The specimen is now moved aside. Now, the previously mobilized colon, transverse colon, and the proximal sigmoid colon or the distal descending colon is laid side by side in preparation for a side-to-side stapled anastomosis. Care has to be taken to ensure proper alignment of the mesocolon of both the proximal and the distal limbs. And after firing the stapler, the staple enterotomy site can be sutured, or as shown in this case, additional stapler can be fired transversely as well. Once the staple is fired, we look for hemostasis, and hemostatic overrunning sutures are placed over the suture line, staple line, sorry. We then place additional sutures to release tension on the anastomotic site. Once again, proper lay is checked, hemostasis is verified, and a drain is placed if indicated. And that's the end of the procedure. Yeah.
Thank you, Shankar, for the nice demonstration of left hemicolectomy.
So,
I think left hemicolectomy is there is no proper definition for left hemicolectomy, as I told in my initial this thing. Depending upon the where the tumor is there, where like compared to right, there is no proper definition. Left colectomy can be there, segmental colectomy there, or left hemicolectomy. But the standard definition, you may have to go up to just remove the sigmoid and go and anastomote the transverse colon to the rectum. That was the definition initially, but according to the tumor site, there is no point in removing more uninvolved colon. But main thing in left hemicolectomy, you have to take the left colic from its root. That is the main thing, because another thing they have found that the Japanese, you may have to take the triple toe lymph node in case of splenic flexure or the distal transverse colon growth, because there is a 10%, 5 to 10% chance there may be lymph node spread with the left branch of middle colic. So that's why you have to take the left branch of middle colic at its root for removing the lymph node, that 10% lymph node. Otherwise, depending upon the person to person, not all the time you can't do the left hemicolectomy like what you have shown in this case. Depending upon the transverse colon mobilization, and the hepatic flexure has to be mobilized in case if you want to do a intracarpal or extracarpal anastomosis. Usually you will be doing only extracarpal anastomosis all the left colon, so it is very easy with less complication. Otherwise, you should have a good skill in doing intracarpal anastomosis, because you have to go for what we have shown is side to side anastomosis, and there should be a important thing, there should not be narrow while you're doing the oblique firing of the anastomosis. That is very important. But mostly you go for a subtotal colectomy or extended right hemicolectomy for the distal transverse or the splenic flexure. Usually you go for a subtotal colectomy where you have a complete clearance of the lymph node, as well as the good you have a good anastomosis also. There's not be any strain in the anastomosis. So that is usually we prefer to go for like that in descending colon growth or splenic flexure growth. Of course, if the patient condition warrants, no features of obstruction, you have a good transverse mesocolon nicely hanging, then you go and do a left hemicolectomy. Anastomosis in that case, you may have to take a proximal sigmoid vessels one, then only you go for a side to side in the sigmoid anastomosis, usually the distal sigmoid anastomosis following left hemicolectomy. Okay, with this, we will go to the final topic, that how to control the perioperative bleeding in colorectal surgery. I think okay. So why discussion on bleeding in colorectal surgery is very important? Because important clinical significance. So bleeding during colonoscopy is a significant due to morbidity and mortality. As we are going towards the CME with CVL era of colectomies, more and more bleeding is expected in the surgeons in the beginning, particularly in minimal invasive surgery, because if the bleeding occurs, it will obscure the visual field and it will increase the operative time. And the intraoperative hemorrhage will lead to increase like infection and anastomotic site leak, and increase because of that there will be increased post-operative complication including re-intervention and the intensive care admission. And excessive bleeding is also associated with a higher transfusion rate. As all of you know, for any cancer patients, if you have more blood transfusion, it will cause immunomodulation, and there is a high risk of post-operative distal metastasis because of the more blood transfusion, because of the immunomodulation. And also there may be a functional recovery is delayed as bleeding correlates with the because of long ileus may be there, maybe increased pain may be there, higher rate of early readmission may be there. All this will lead to increase in length of hospital stay. So what is the major cause of bleeding you can incur? Because major cause of bleeding during surgery, it depends upon various factors, patient related factors, intraoperative vascular anomalies may be there, poor surgical technique. I would say main first will be the poor surgical technique. You should be very much experienced in doing the minimal invasive colorectal surgery. Most of the time the early stage of your colon will come across because you have a less anatomical knowledge. And intraoperative vascular anomalies, yes, you should be aware of the vascular anomalies, particularly if you're doing the colectomies both right and left. And patient related factors, as I already told, if the patient is having chronic steroid intake, inflammatory bowel disease, cirrhotic patients, previous radiotherapy, chemotherapy induced, all these patients you expect coagulation abnormalities. So intraoperative vascular anomalies, yes, variant origin in the inferior mesenteric artery while doing left hemicolectomies or other anterior section. You should know about the middle colic branches and accessory renal artery into the surgical field while doing a left hemicolectomy. All these patients, and if in case of cirrhotic, you may have excellent or multiple collaterals you should expect. So, what are the what are the various causes of intraoperative bleeding while doing surgery, while doing particularly minimal access surgery or laparoscopic surgery? Number one, while putting the port itself, you can have bleeding from the epigastric vessels, inferior epigastric, superior epigastric or branches, or bleeding from the IMA or IMV, bleeding from presacral plexus of veins while doing anterior section, bleeding from gastropancreatic colic trunk while doing the right hemicolectomy, bleeding from SMA, SMA, or bleeding from gonadal vessels, bleeding from small bowel mesentery. All these things can happen while you are doing the colectomies, whether right or left or anterior section. And you should know the importance of right colon vascular anatomy. And for right hemicolectomy, there is a need to understand the complicated vascular branches in order to dissect the lymph node and to further identify and dissect the correct blood vessels. The branch morphologies of the right colic vein, middle colic vein, and gastrocolic trunk are highly varied, and with both the head of the pancreas and duodenum in close proximity, D3 lymphotomy is considered to be highly difficult surgical technique. So this was done in by the article given by the Japanese Obara in 2021. So the understanding the complex 3D anatomy SMV and SMA is paramount importance to minimize the iatrogenic injuries, because the conversion rate laparoscopic to open is around 10 to 20%, and one of the most frequent reason is for the intraoperative bleeding. So the vascular anatomy, this is the SMA variation. You can see usually ileocolic artery is 99% will be there. Middle colic more than 90%. The variation will be from the right colic artery will be absent at up to 20 to 60%. So it can arise from the superior mesenteric artery, or it can arise from the ileocolic, or it may arise from the branch of the right branch of middle colic artery. So multiple studies have shown that frequency and pressure of right colic is approximately 20 to 30% only it will present. Although one study report around that middle colic artery forms common trunk in approximately 80 to 90% cases. So variation, the The report rate of intraoperative bleeding during minimum invasive colectomies range from 3 to 9.2, nearly 10% case. That's why the conversion rate to 10 to 20% because of the bleeding. And one study, they said ileocolic and right colic artery had a trajectory posterior to superior mesenteric vein in 57% and 10% of it. Most of the time, you can see around 60% the ileocolic vein will be anterior and the artery will be posterior, and vice versa in 40%. So you should be very careful which one you are going to approach, whether it is vein is first or artery first. Sometimes artery will be anterior and vein will be posterior. So the intraoperative anomaly failure to identify vessels. So you, while dissecting, you can do the inadvertent injury to the anomalies. When vascular anomaly is not clearly visible, bleeding may result from laceration during mobilization of the mesocolon or pelvic dissection. That's why our IETA technique for right hemicolectomy will avoid. So SMV and SMA pedicle, superior mesenteric vesicle, are released from the retroperitoneal attachment in our IETA technique. That because of that, while even the traction will not cause the laceration of the small vessels. So this is one of the doing the right hemicolectomy, a little bit obese patient. You can see obese male patient. So he is going for the SMV. So you can see directly bleeding from the SMV. So immediately what you have to do, you have to keep pressure over that and do a suction and give a suction to your assistant and take a bite. So you can see how this has been tackled perioperatively, bleeding from the ileocolic vein attachment to the SMV. So this has been tackled with the 30 PDS. You can see 30 PDS, or you can take a 30 proline. So you should be careful in obese patient, as I said, while doing the surgery. So tackling the SMV is very important. So bleeding should not have. If you have a more bleeding, immediately, if you can't control, you may have to uh, open the case, because more bleeding, it will have a small bowel congestion, then there may be problem. Uh, So how to control? Always test vascular pedicle before cutting to ensure complete control. Use staplers for large vessels. Must be carefully executed. Adequate exposure. Keep ready with open table. Low threshold to open. That is very important thing. And the important thing I want to say is the inadequate proximal vascular control before transaction, especially in IMA, leads to sudden arterial spurting. Improper clip placement or partial ligation of the veins lead to oozing. So this is another case. See how very cleanly done case. The tip of the, while handling the ultrasonic session, you have 100-degree at its tip. You should be very careful. So I am just at the tip of clearing the IMA. It is just arising from the aorta. So because of the tip, just you can see it will be hitting the, it is a bleeding from the IMA. So immediately you have to catch hold and just try to apply the clip. So there is this is one of the live demonstration actually. You can see in the PIP view. So after controlling, I thought because of the traction, it's more. So I divide the IM way, but still I am holding with the clip applicator, the main this thing. So we applied the clip, then we used the suture, nicely taken, but while tightening the knot, it has kept over the clip, so it didn't work. So immediately what was done, it was opened and cleared. The incision cleared because it has hours from the aorta, so you have to suture with the proline, and then again we continue with the ultra low anterior section with the laparoscopically. So you should have a low threshold to open. So in such situation, you should not go on the middle of the patient immediately. You should go open and tackle the condition. So in case of presacral bleeding, injury to the preclavian venous plexus or in the internal iliac vessels or their branches. So presacral bleeding may be from the presacral venous plexus or from the branches of the internal iliac vessels, occur mostly in 4 to 7% of the procedure. Most common complication during anterior section, that is the ultra low or anterior section. Usually, what are the causes? Mostly causes if the tumor is fixed to the sacrum or preoperative radiotherapy or previous pelvic surgery or a distal location of the tumor, very ultra low or surgical maneuver that violate the presacral fascia increase the risk of presacral bleeding. If you go beyond the presacral fascia, there is a high chance you go injure the presacral plexus of veins. It is very difficult to control because it has a high intravenous pressure is there, more bleeding will be there. It is very difficult to control. So only thing is a main thing you have to initial manage to apply direct pressure over the bleeding site to achieve temporary control. Then you can have, if you have a bone wax or bone cement, you can apply, or you can apply the epiboloic flap or a omental flap to make a pressure over that, or you can use a rectum some muscle bit and keep over that and keep a bipolar. So you have to cauterize that with the muscle so that it can form a compression over that bleeding veins, or you can have a balloon tablet using a saline bag or a breast implant, or you can have a hemostatic sponges with cyanoacrylate adhesive, or you can have a spray diathermy. These are the various measures you can have to control the presacral bleeding on table. This is one of the this picture shows how the vein suture during the anterior section, bleeding from the branch of the iliac vein. So what are the various hemostatic tools can be used intraoperatively? So you can use a bipolar cautery, you can have a ultrasonic dissectors, which are commonly used, but their misuse can cause thermal injury and bleeding. So topical agents like oxidized cellulose or fiber and sealant as adjunct for using from a raw surface, where you can't use clips or sutures, but you can use from a spray so that the ooze will be stopped from the retroperitoneal structures. And you can use a bulldog clamp, a hemoclip, and double ligation method in key is a key for secure vascular control. Fluorescence angiography allows assessment of perfusion before finalizing the anastomosis. Of course, ICG can be used for perfusion. Keep suction device ready to maintain the visibility during active bleeds. So future direction. So real-time vessel mapping via augmented reality, that is AI enhanced imaging, is under development. These will reduce the risk of intraoperative vascular surprise. So future you may have a picture while doing surgery itself. It can give the surgeon's guide, or it can give a hint that you are going close to the vessel, or there may be some abnormal branch. So all that it can dictate while doing surgery itself. It can be imposed with the AI advancement. So advanced vessel sealing system and pressure responsive staplers are also evolving, so that you can use wherever the pressure point. So this picture shows the where the vascular bleeding is occurring, and these are the some pictures which shows that where possible area of vessels there while dissection. So future will be a perfusion sensor. You have a squid device that provide quantitative tissue perfusion feedback at the anastomotic site, so which will show the vascular supply of the anastomosis. The squid is a superconducting quantum interference device magnometer, is capable of non-invasively detecting mesenteric ischemia reliably and at an early stage of by detecting significant drop in basal electricism. So machine learning models predicting bleeding risk based on patient data are being integrated into surgical planning platforms, so that which patient is going to have high risk of bleeding while doing surgery. So they have a logistic regression and gradient boosting machine models are there. So future may be guiding the surgeons doing a bloodlet surgery. So thank you very much for patient listening. Hope you all of you have enjoyed this session this month at Televersity, and hope it was useful. And I thank all the speakers and Harish, Shankar, and Muthu for their wonderful presentation. If there is any questions, Uh, I'll answer. Some question as what is the ICU stay? Usually, as I told, post colectomy ICU on the day of surgery. Next day, patient will be in the room. Mostly, fourth or fifth day, they will be discharged. Any more question is there?
Sir, during minimal invasive surgery, during the bleeding, sir,
Yes.
when you are if it is not controlling, you
Yes.
are planning to open. During the meantime, do we need to take any measures, sir? Which is ongoing bleeding will happening
So
inside?
bleeding is from the vein or artery. So these are the two important things. If you are good enough experienced for arterial bleed, you can have if you have a control over using a artery forceps like Maryland forceps, if you have a control and if you have a stump in the left hand, if you have a control and if you have a stump within the artery forceps, if you can apply a clip, immediately you can apply a clip. Otherwise, if you have no other measure, if it is artery bleed, will be very fast. Within minutes, the patient go for hypotension, they will collapse. Okay, particularly if the bleeding from the inferior mesenteric artery or from superior mesenteric artery or from middle colic artery. So these things, if you can't have a control, immediately you have to open and control. There is no other way. If it is a vein, yes, you can do a compression, you can wait for some time, or you can call for a help, or you can go and try to suture, or you can have a compression or a clip if it is suitable. But otherwise, you have a low threshold to go for a open because our aim is not to do the surgery. We should not lose the patient by waiting for a long time. Of course, anesthetist will be showing you should not wait till the going patient go for hypotension or they have to start with the noradrenaline everything because in that case, whatever anastomosis the patient go for because of bleeding, patient go for hypotension and you go and do a anastomosis. That anastomosis will leave because of the ischemia. So all these things, if you are doing anti-resection, definitely you have to go for a diversion for such patient, even though if you are very good with if the leak test is negative. So if you are right hemicolectomy, you should be think twice, go for the anastomosis because anastomosis can leak if the patient is having perioperatively go for hypotension because of the bleeding.
So doing proximal ileostomy is very
Not all the time. So if you have a ICG and if you have ICG, good vascularity is there, patient gained normally, you have adequately replaced the loss and you are very good, then you can go. And patient is not like a normal patient does not have a comorbidity, then you need not have. But if the patient is already a sick patient, multiple comorbidities like long-standing steroid intake or long-standing antiplatelets. So the such patients you expect something and you may have go for a proximal ileostomy or don't anastomosis. Later you go for anastomosis.
okay. Sir. Thank you.
Any question? So now the question is anesthetic consideration for tackling bleeding. As I told just now, the anesthetics play an important role. Once the bleeding is there, they will be in close watch, and when they will assist you or they will instruct you to open immediately. If there is already 500 ml of blood is lost, or it's going to more than 800 ml, then they will say better to open and control. Otherwise, they don't want to have more loss to replace the volume. So that's why we should have patient should not go for a hypotension. They should not depend on the NORAD support or blood, all the things there. So you should not wait for the more cost.
Sir, how we have to plan in post-operative period when patient is having bleeding? So how to balance between the Clexane we have to stop and when we have to stop the start the Trenexa, or when we have to intervene?
Yeah, the patient, for example, previously pre-operative patient is on antiplatelet. So these patient will have bleed post-operative. So you have to wait for the patient will be on Clexane post-operative. That patient is going for a bleeding. You have to stop the bleeding. So you see if the patient is going for bleeding and hemoglobin less than 8, you may have to go for a blood transfusion 1 or 2. Then if the patient bleeding is coming below 8, then the risk of patient having complication with the bleeding is more than the risk of having patient having some episode of ischemia because of the without Clexane. So you have to wait. So in such cases, patient is receiving hemoglobin blood, then you have to go for a tranexamic. You have to do a Zamic. Then once it's controlled, then you can restart after 5 days. So once you stop the Clexane and you start the Zamic, that is tranexamic acid, if the bleeding stops within 24 to 40 hours, they continue for another 2 days. Then you stop tranexamic. Then you can start the Clexane. So, but usually you wait for like 4 or 5 days. Once the bleeding stops, once the patient starts taking normal diet without melena, patient pass motion, then you start. But all these things you have to do the coagulation profile all the patient. Bleeding time, clotting, PT, APTT. If any abnormality, you have to replace that.
And sir, all ongoing bleeding patients first will go for colonoscopy method.
Ongoing by immediately don't go. So patient is after 3 days or 4 days. For example, if you have done a colectomy, hemicolectomies, or anti-resection. So anti-resection, there is a bleeding. Fresh bleeding is coming. Immediately you can put a scope and see. You can just use endoscopically. You can use clip or you can use hemostatic powder, or you can even some injection also to stop the bleeding because anastomosis is below only. If it is a colon, if immediate bleeding, depending upon the mild bleeding is there or only melena is there or fresh bleeding is there, patient is not tachycardia, wait for 20 to 48 hours. You replace the blood, you stop the Clexane, you give the tranexamic acid. Patient most of the time it will stop. If it is not stopped, even after like 48 hours or after 2 or 3 days, but under control, patients not having hypotension or tachycardia, then you can try like after 3 days, you can put a colonoscope, you can prepare the bowel and you can go and see there is active ooze or bleed is there. You can apply clip colonoscopic now if there is an expert available, or you can just spread the hemostatic powder to stop, but mostly it will get stopped. If it is not, if there is ongoing bleed, patient is having a fresh bleed, multiple transfusions required, patient's tachycardia, then you have to take for surgery. Go dismantle. There may be one vessel is bleeding continuously. You have to just clip it or suture it and re-anastomosis. Or you can just open the distal or proximal to that
Anastomosis.
distal to the anastomosis through the colon. You open it and only suture the bleeding point and suture the colotomy wound and come out. Okay, if there is no more question, thank you very much for watching, and thank you for all the speakers and the moderators. We'll see next month. Hope it was useful for all the viewers. Thank you very much.
Thank you, sir.
Thank you.
It's time.